Bam.
Bam. Here, actually, in celebration of my favorite holiday ever, I put on my costume. Is that okay?
Oh my goodness, yes.
I turned into a cat.
Are we that close to it?
It's the month. You got to celebrate the whole
Oh,
month.
oh, Halloween month. All right.
Yeah, I like your costume. It's very scary. It's so good to see you, Dr. Rosensweet. Happy, happy day.
You too, Carolyn.
Thank you. We have our questions as we always do, and I'm going to welcome everybody who's going to be coming up and say hello and send love. And thank you for being here. Love doing this. It's very cold here in sunny California. It's like rainy, thundery, weird. So it's kind of cool. Okie dokie. Ready for number one?
I'm ready.
All right. You guys don't fight. No. Can you, Dr. Rosensweet, take progesterone and estrogen together?
Well, together, I mean, every woman in the menopause should be taking both progesterone as a hormone to replenish because the ovaries aren't doing it anymore.
Right.
And also estrogens, bias preferably, topically for sure. But we administer them in the menopause method as separate entities. They come in two different bottles.
Looks familiar.
And here's one of the reasons. We like to divide the estrogen dose into twice daily. The ovary didn't wake up in the morning and just shoot all the all the estrogens out into the bloodstream all at once. No, it's a much more of a timed and a predictable stream there. And when you administer a hormone, no matter how you administer it, when you take the dose, that's when you get the highest peak in the blood.
Right.
So peaking of a hormone is an unnatural process. Doesn't ordinarily occur. The ovary doesn't shoot it all out at once. So what we like to do is at least divide the estrogen dose. We don't like estrogen peaking. Instead of giving it once a day, we give it twice a day, morning and evening. And that's two different doses. That's dividing the dose. You get two much smaller peaks when you apply it topically. Bias should always be applied topically. Almost no exceptions to that. There is, of course, in medicine, there's no such thing as no exceptions. There's always an exception. But progesterone is a great calmer. It's such an unusual hormone. Almost every hormone you can name is animating. They're part of the fight or flight response, the biochemistry of running from a saber-toothed tiger. Estrogens are animating. Testosterone's animating. Adrenaline's animating. Cortisol is animating. They're all everything you can name with the possible exception of melatonin, and certainly including progesterone, is calming. It's the great calmer. So we love to give progesterone primarily at night, at sleep time. So two different bottles, estrogen, progesterone. We give the estrogen twice a day, morning and usually at sleep time. And we give the progesterone and the estrogen, different locations on the body, topically at sleep time. Now, there's even exceptions to that. Some women also actually feel animated by bias, and they cannot take the bias at sleep time.
Yeah.
They need to take it earlier in the day so they don't get animated.
Right. Right.
And so we encourage women to find their optimal time. Some women can take in a couple hours prior to their progesterone or their sleep time. Some women have to take it in the afternoon as their second dose. And that way the animation will have worn off by the time they go to sleep. Progesterone, we always recommend that you take it at sleep time. Here's a couple other exceptions. there's a lot of women, a high percentage of women that do better on oral micronized progesterone, especially those who are having a certain type of sleep challenge. Oh, sleep challenge are 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 monumental and epidemic in menopause. There's two aspects to sleep challenge. One of them is from the low estrogen. If you're waking up in the middle of the night with a hot flash, you got a component that you need to replenish those estrogens. But there's also a common sleep challenge that is beautifully alleviated by progesterone. In some women, the topical progesterone works just terrific to do that. But other women need higher doses, and we need to give them orally. And there's a special sleep benefit from one of the metabolites of progesterone. So it's very common for providers who can prescribe to prescribe oral progesterone at night. And then we just had a question come in: how much progesterone is necessary postmenopausal? Well, it's like any other hormone at any time. It's individual. We don't know what your dose is, but we give you guidelines on how to find your dose. So our protocol with topical is you apply the progesterone at sleep time. And if you apply too much, your body has too much, you're going to wake up still feeling the progesterone you took the night before. And what are you going to feel? Like you took an overdose of a sleeping pill, or you're going to wake up feeling groggy, as if you took an overdose of a sleeping pill. So what would you do? The next night, you'd back down on the number of drops you used. This is called dose titration by symptom alleviation. Gradually increasing the dose until you alleviate symptoms of hormonal insufficiency while backing down from dosages of hormonal excess.
Right.
Excess symptoms. Now, there's yet another. So how much? The most common range of progesterone in my practice topically is usually, it's usually up to 6 drops of our topical progesterone, 200 milligrams per milliliter, which is about 50 milligrams topically applied to the skin. We usually have women apply this to their inner thigh. Or if we're going to go to oral, we give women 2 different bottles of oral micronized progesterone from a compounding pharmacist. One of those bottles contains 30 capsules of 25 milligram progesterone in capsules, and another bottle contains 30 capsules of 50 milligram. And we'll have most women start at 50 milligrams and see what they take it at sleep time, and they see what the effect is. Some women actually do well on 50 milligrams, really supports their sleep. They don't need more. If a night or 2 or 3, the woman is not sleeping better, we'll have her take a 50 milligram capsule plus a 25 milligram capsule, total for 75 milligrams at sleep time. See how she does with that. If she doesn't feel the beneficial effect with that, we'll have her take again, we'll have her increase the following night or wait a couple nights to 250s, which would total up to 100 milligrams. See how she does with that, et cetera, increasing every night or every 2 nights or every 3 nights the dosage to find your optimal dose. And it's very common in our practice to have women do well anywhere from 50 milligrams to 225 milligrams, that wild a range. Well, women are individual. This is why we always customize, individualize dose determination. I'd say the most common in my practice is somewhere between 75 and 150 milligrams, those dose ranges. And then once the woman determines what her optimal dose is, we have the compounding pharmacist make up a single capsule. So let's say that she figured out it was 150 milligrams. We'd have the compounding pharmacist make up 150 milligram capsule. Now there's another exception. And women taught me this, as I learned so much from women over the course of many years.
Well, you've listened too.
They show up for a follow-up visit and they say, boy, I love how that progesterone calms me down at night. And I've had daytime anxiety that just came out of the blue. I'm not an anxious person, but man, when I went into the perimenopause, I started getting anxiety. I couldn't even figure out what the heck it was. Could I take progesterone during the day? And what did I know? This is 25 years ago. I'm figuring it out from scratch, pretty much. A few tips from some colleagues. I said, sure, try it out. And they'd say, I already have, and it works great. So we have many women who are also taking appropriate amount of progesterone during the day, either topically, and for us, it's the organic oils delivery system, or through oral. And what do we caution women? Don't take so much progesterone during the day that you get groggy so you can't operate heavy machinery as in an automobile, etc.
Or that large crane.
That large crane that's outside your front door.
With the saber-toothed tiger. Go
oh my
together.
God. Got a lot of equipment out there, Carolyn.
Oh, yes, indeed. We aim to please. It's a fun place.
So women also titrate their daytime dose to figure out what is the calming without too calming.
Right. So I mean, I'm sorry. But I do know that certain women have been given a combination of estrogen and progesterone in one thing.
Yes.
Not
and
your favorite.
There might be certain women that tolerate and do just fine on that. And there's a cost effectiveness in that. Now, how would they do that? This would be topically. We don't want to have combination estrogens taken by mouth. They're pro-inflammatory. They increase liver production of inflammatory proteins, and they're pro-coagulative. And nobody, especially in this era of COVID, one of the worst things that happens in COVID is microcoagulation in the lungs. When you see someone have breathing trouble in COVID, this is primarily from microcoagulation in the lungs. I highly recommend our dear colleague, Dr. Lindsay Berkson. She's put out some remarkable interviews of some COVID experts. Jeez Louise. Lindsay Berkson, Dr. Berkson. If you have any questions, perhaps, Carolyn, you could post a link to Dr. Berkson.
I will. I have. They go down.
I know this isn't what the question. It's not what the questionnaire is asked, but we don't want to take anything that is promoting coagulation. And anytime Americans, instead of being spot on coagulation wise, there's a hypercoagulation going on in this country for a lot of reasons, probably on this planet. We don't want that. We don't want excessive clotting. We want spot on stuff. So if you bleed, you don't bleed too much. You clot. You don't clot too easily. You're spot on. Well, there's not spot on going on this planet. There's a tendency towards hypercoagulation, not because of infections, occult infections with viruses, because our immune systems aren't necessarily doing the most sterling job that young people's immune systems do. So, we're wandering into the weeds again, Carolyn.
We are indeed, but it's always interesting. We always learn. You're amazing, and I know I think so, and I know a whole lot of other people think so too. So, yes.
My favorite way to do hormones, they're so powerful, they're so essential, is to do it right.
Yeah.
And let's copy nature as best as we can.
Yes.
And so you'll see in the menopause method and that we're very, very specific about all this stuff, and we don't combine our estrogen and progesterone.
Okay. I got to ask this question, and then I'm going to move on to my next one. But the question is, we've talked of this so often in regards to progesterone. What if the test shows too much progesterone, but it feels good?
Which test are we talking about?
I don't know. I guess the progesterone test.
Well, I am a staunch non-advocate of any method when you're testing a woman in menopause being treated with hormones. The only method that I hold is valid is the 24-hour urine hormone test, not other urine hormone tests, not salivary testing, not for estrogens and progesterone. No. And I've seen all kinds of values that just staggered me that didn't correlate with the clinical stuff. Now, I know there's a lot of folks who'd like to debate me on this. Fine, let's do it. But at any rate, what I can highly recommend to you is the 24-hour urine hormone test. It's going to tell you what's going on in anything that you apply topically. Oh, what about oral?
Ooh, yeah.
You're going to get a super accurate correlation between progesterone applied to the skin, but when you're taking oral progesterone or oral anything, any oral hormone, there isn't a good testing method as far as I can gather.
Right. Well, she said it was a urine test, but my curiosity got piqued because we talk about progesterone and that you can go pretty high with progesterone, can't you?
Oh, yes, you can go pretty high. But when you're taking any hormone orally on 24-hour urine hormone test, you are not going to get the kind of results we wish we could get.
Got it.
Because 80-90% of what you take orally goes from your intestinal tract directly to your liver. It doesn't go right into the main bloodstream and get circulated to the blood and then circulated to the whole body. Like it doesn't apply it to your skin. That's how that works.
Right.
When you take it orally, it goes directly by the hepatic portal vein to the liver, where 80 to 90% of it is metabolized. So if you take 100 milligrams of oral progesterone and you look at a 24-hour urine hormone test, you're going to see really astronomically high levels of the principal metabolite, which is how we assess progesterone in the urine. And so you can get somewhat of a guess. I mean, laboratories often recommend that if you're taking oral progesterone, you omit it the night that you're collecting your urine and the night before you start to collect your urine. That's going to give you somewhat of an idea.
Yeah.
But really looking at the afterglow there. So, moral of the story is this. Work could be done to assess progesterone treatment through blood testing, but I haven't seen the research done. And there is no rush out there to try and assess progesterone levels. You don't need to. The stuff is so safe. And it's very rare that someone's going to take an overdose of it because they're going to be so groggy. They're not going to like the grogginess on overdose. And it's a good idea to really take maximum amounts of progesterone. Really helps the thyroid gland, really helps the estrogen receptors become sensitive to estrogen itself. Oh my God, where are we going with that one? The orchestration is just incredible. So good for the bones. It's the only substance I know that supports the osteoblast to lay down new bone. So although I find it critical to test estrogens, topical estrogens, and topical androgens, and you shouldn't be taking estrogen and androgens, for 99.99% of the human population should not be taking them orally. Estrogens or testosterone, no, not orally for those two. You're going to get wonderfully accurate results on the 24-hour urine hormone test. So, and there was one other question about progesterone I saw flash up there. Do you want to read that one from V?
She said, "Can progesterone make you gain weight?"
Such a common question we get.
Almost every time.
Yeah. Do these hormones help me to gain weight or force me to gain weight that I don't want to gain?
Right.
The answer is not if they're done properly.
Right.
If they're done improperly, you're at risk for all kinds of stuff. Nothing too dangerous, but all kinds of stuff.
Right, not to be scary. Yeah.
But it's very common for a woman who's in menopause to start taking hormones and immediately gain 1, 2, 3 pounds. And one of the reasons is that estrogen is such a great supporter. That's estrogen I'm talking about. Estrogen is such a great supporter of adequate hydration in your body, and including the skin, that immediately, if you've been low on estrogen and you start taking estrogen, you're going to gain some water weight, and your skin is going to look so much better. Instead of being shriveled and wrinkled, if it's gone that far, you're going to see the skin plump up again, like a young woman's skin.
Right.
The amount of recovery there can be beautiful. You really, we don't know how far you can recover if you've been gone for many, many, many moons without estrogen. But that's the most common thing, is you get a water weight gain. Now, progesterone is a diuretic. And if you don't have enough progesterone, you're not going to get enough loss of water, appropriate loss of water. So you get the right amount of progesterone, and you're going to be peeing out the proper amount of water. So the whole trick is getting the proper dose of estrogen, proper dose of progesterone, eventually test it out. Now, there is abnormal weight gain from inadequate ovarian hormones. You don't see young women. I mean, the ovary puts out in young women this maximum amount when a woman's 20 plus or minus 2 years. These are really the most robust dosages for ovaries are ever going to put out. And a lot of women, young women, maintain very thin, very, very wonderful body weights. It's when they tend to get older, when the hormones are declining, that they tend to start putting on weight in unwanted places. And it relates, from the best I can tell, from metabolism. These hormones, like progesterone, for example, it facilitates metabolism. Metabolism is what takes place in all the cells in which you combine oxygen with the ultimate food products that you've eaten. And you produce energy and heat. This is the biochemistry of energy and heat production. So great mystery that I didn't really figure out until a couple of years ago, that why in the world would a young woman test whether she's ovulating or not by taking her basal temperature every morning? Because if she ovulates mid-cycle, her temperature goes up. Huh? How'd that happen? Well, it's because if she ovulates, and only if she ovulates, she puts out a very robust amount of progesterone mid-cycle. Huge amount. 100 times the amount, milligram per milligram, of estrogen output. Huge. And one of the things that progesterone does, it facilitates the action of thyroid hormone. Holy mackerel. Thyroid hormone is one of the principal biochemicals that animates metabolism. Low thyroid hormone, low energy, nothing works right. It doesn't work right. Yeah. You get constipated. Your immune system doesn't work right. There's problems with that. I'll tell you, low thyroid hormone, low energy. So if progesterone is facilitating the function of thyroid hormone, when progesterone shoots out into a woman's body mid-cycle, from if there's ovulation and from the ovary, her thyroid hormone works better, and she actually gets increased metabolism, thus increased energy plus increased heat. So her temperature goes up. You want good metabolism to maintain good body weight. So you want progesterone to do so.
So is it balance and
let's get it right. Just
get it right.
Always get it right. Don't do too much and don't do too little. And we describe, in fact, you have offered to the public a no-charge PDF version of our book, Happy Healthy Hormones. There is one description. There's descriptions in there on how to get it right, how to get it individualized.
Yes, and the charts are up there too, and Happy Healthy Hormones. There's really good information there. Thank you, Dr. Rosensweet.
Now there's more. Estrogen is an animating hormone.
Right.
In fact, it is recruited for fight or flight,
which we need.
When we get challenged by a significant threat, like a saber-toothed tiger, we mobilize a biochemistry that's just so awesome. We can run from that saber-tooth tiger. I think I don't recall the last time that I personally ran from a saber-tooth tiger. Do you recall the last time you
I
did?
do. I saw you, and boy, you were moving.
Thank you.
You recruited in those fight or flight hormones like anything I've ever seen.
How about you? Were you moving too when that saber-tooth tiger?
Yeah, you were following me.
That's right. I seem to remember that. I'm not exactly clear on that
It
memory.
was about 5 billion years ago, but
But
it's okay.
when we did a 24-hour urine hormone test while you were running, we were collecting your urine. We saw astronomically high levels of estrogen while you were running from that saber-tooth tiger. I think that's how we did that back then.
Yeah, recruited in for that very reason. Go
Well,
figure.
because estrogen is terrifically animating. So is a woman's testosterone. So is a woman's thyroid. You want every powerful animating biochemical you can in a fight or flight situation. And so you lose the animation, the metabolic animation of estrogen, and what happens? You don't metabolize as well. You don't produce as much energy and heat, and you tend to gain weight, especially if you're not eating well, etc. And you're not exercising properly because you don't feel like exercising. And yet another contributor to that is you've lost a significant percentage, if not almost all, of your testosterone coming out of your ovary too, which is very motivating. Get you to the gym, get you walking, get you up and moving. Androgens, female androgens, testosterone, the queen of the female androgens.
Right.
Male hormone, it's a human hormone. So all of this stuff, the moral of the story is it comes down to the exact same thing for every single woman. You need to find a healthcare provider who is prescribing ovarian hormones. Compounded bioidentical hormones are absolutely far and above my favorite. And they know what they're doing, and they know how to individualize it to you. And you can contact us at the Menopause Method. But the bottom line is you want expert individualization. It may take you a while to get it just right. Get it, what does your body need? Women vary woman to woman as to how much estrogen they need, how much progesterone they need, when they need it, how much testosterone they need. So it's not rocket surgery, though. For someone who knows what they're doing, they know how to guide you into figuring out the optimal dose of all these different hormones. Plus, they know how to do the 24-hour urine hormone test to make sure that when all is said and done, and you say, I'm feeling better, that you're sitting within scientifically valid ranges. So
Yes.
your estrogens, for example, are sufficient to protect your vagina and your bones, minimal.
Muscles.
Yeah, and your testosterone levels and DHEA levels are right in the zone to protect your muscles so you do not lose muscle.
Correct.
And progesterone, we're not so reliant upon getting adequate progesterone levels by testing. We don't need it. We definitely want you to have enough progesterone. We can test you another way. If you're taking estrogen, we don't want you to form an endometrial lining and keep menstruating for 95% of the women. There are exceptions to that too. But we want you to have enough progesterone, and we can assess adequate progesterone in a lot of ways. And one of them is you're not bleeding. That matters. And here's another way. We do a transvaginal ultrasound to make sure that you're not forming an excessive endometrial lining. So we do those periodically on select women. So there's ways to test all of this.
Thank you, God.
If your head is spinning because of the amount of information involved here, sooner or later you'll get it. Read the book. You'll get so knowledgeable about this. The great news is, let me tell you what it was like for me starting to treat women in menopause 25 years ago. I had almost zero sources of information.
Yeah.
I had the great benefit of hearing from Dr. John Lee that progesterone's good. That was about it. Nowadays, it's entirely different. There's fabulous information and fabulous clinical experience out there for those who have really specialized in this. And so you can learn a lot. But here's the main thing you need to learn: you need to go shopping until you find a professional healthcare provider that can prescribe hormones, who's really taken a special interest and got special training and has special
Yeah.
experience in treating women in menopause with compounded bioidentical hormones. That is your job.
And it's so worth it.
Let them. It's like I used to work on my own automobiles. I even rebuilt an engine in my Corvair van. Think about that, Corvair van, the 1970s. We're talking about. I think I rebuilt it in 1970, and it was fantastic to rebuild that whole engine. I just thought it was amazing. And then I rebuilt it and it ran 9,000 miles. Fantastic. At which point it ground to a halt. Many years later, when I went to have my Volkswagen engine rebuilt, my Volkswagen van engine rebuilt, I went to a professional mechanic who had rebuilt hundreds of Volkswagen, and he let me watch him do it. And I saw the 100 different things he knew that I hadn't even thought of or dreamed of, steps in rebuilding an engine to get it right. So, moral of the story, I stopped trying to service, especially deep service, any of my automobiles. I take them to someone who does it all day long.
You didn't do a deep dive into the land of Volkswagen engines? You tried?
I didn't. I watched them do it. And, hormones are like that. You want to find someone who's really had a lot of training and a lot of experience. And then they're going to know how to guide you on your individual program. So your job becomes, how do I find out who in my town or now in my state? Because with telemedicine, in the menopause method, we only advise women. We only treat women by telemedicine. Because it can be done, menopause can be done beautifully via telemedicine. So you just need to find someone in your state that knows what they're doing and is doing telemedicine.
And slowly but surely, they are coming aboard, and I'm seeing it, and it's very exciting.
Yeah.
And yeah, it is. And much and great thanks to you and your training of many of these doctors.
That's my favorite thing to do.
Very quickly that you, David Rosensweet, MD, were the first doctor to train the very, very first nurse practitioners ever. To me, that's huge. 6 of them.
1971 in Albuquerque. I know their names.
Yeah. Well, I know one of their names, Deborah. That's the one I can remember.
Wow.
But I think that's fascinating. And so I'm going to go to because we were talking about androgens, and it's something that we bring up. Women write it to me all the time. Anyway, we're talking about DHEA, and a couple of interviews ago, you and I discussed low DHEA. This question comes in saying so many women are really confused. Women are so scared to take DHEA, either due to its being too high without even taking it. So why would I take it if my DHEA is high? If they're too low, if a woman is too low, she's being told to take it, but she's petrified that if she does take it, she's going to lose her hair. So there's like this weird thing going on with DHEA that I don't understand. I believe you do, be it too high or too low. In this particular question, it's presenting as having too high of DHEA on one's own, yet being told that it's a very important hormone to take.
I have a fabulous response for this.
Drum roll.
Is I'm not going to respond to it right away. I want to respond to it. Finish off the progesterone question.
Okay.
This came from Rita, and she says, "What if the test shows too much progesterone, but it feels good?"
Yeah.
Well, I did already address that. What test are we talking about here? If you're taking oral progesterone, the 24-hour urine, probably every test you're going to do is going to show it too high, because you're going to be measuring the principal metabolite. And if you take it orally, 90% of what you're looking at is what the liver processed before it had a chance to even go to the rest of the body.
Right.
Now, again, with progesterone, it's very unlikely that you're going to take too much of it. It's like thyroid hormone, or it's like almost any hormone most of the time. Unlike cortisol, when you can take too much cortisol, you can get high on cortisol. So you don't have a built-in safety in treating with cortisol. People get high on excessive amounts of cortisol, but not true with progesterone. Oh my God, you're going to get groggy. You're going to feel drugged. You're going to get depressed. Most women are not going to like too much testosterone, too much progesterone. They're not going to do it. Same with thyroid hormone. You're not going to take too much thyroid hormone. You're going to get racing heart, tremors, palpitations. You're going to feel like you were jacked up on 18 cups of coffee.
Ugh.
These hormones are so powerful that if you take an overdose for most of them, you're going to get symptoms that you're not going to like.
Right.
Estrogen's a little more tricky there. And so I'm not going to go into that. But the question was around progesterone. So you're not going to take too much progesterone. And progesterone is tremendously safe. You're not going to take too much because you're going to feel groggy. Most women will. So just, if your progesterone is being prescribed by a professional who understands about progesterone, they're not going to give you too much. It's not going to do it. They know it. They know their numbers, especially around progesterone. A lot of prescribers don't know their numbers. But especially around progesterone, it's so commonly known. So that's what I want to say about that. Now let me talk about DHEA.
Okay.
DHEA is a prohormone. It doesn't exactly do what other hormones do. It's in this gray area. For example, we list symptoms, and this card has been published on Ins and Outs of Menopause. We list symptoms of too little and too much estrogen, too little and too much progesterone, and too little and too much testosterone. We don't list DHEA on there because it's not necessarily, too much DHEA is not necessarily associated with adverse symptoms. Although because DHEA can convert to testosterone or estrogens, you can get, like there's some women who take too much DHEA, they get oily skin and pimples. But let me give you some guidelines about DHEA. Number one, like men, like women, probably like most of the animals, the mammals, the peak DHEA, like in all hormone output, is when you're 20 plus or minus a couple years. From that point, your DHEA declines. I'm not necessarily going to call that natural, but all these hormones, there's increased demand. We're calling on the fight or flight biology in ways that it would be better that we didn't call on it as much as we do. It's good for saber-toothed tiger attacks, but better we should be more skilled with our emotions and our mind, that when our bank account drops, we don't get so bent out of shape as to equate it biologically with a saber-toothed tiger attack. But I do hear, it's a rumor, that there is stress on this planet.
Go figure.
And I do hear that not everyone is equipped with the tools of emotions and mind to do terrific with it. And they are triggering the biology of the stress response. And they are tiring out their adrenal glands and their ovaries and their testicles, all of us.
Right.
So, and midlife, the DHEA levels when we do 24-hour urine hormone testing are never normal. I've never seen one. that is youthful. I've seen hundreds and hundreds and hundreds of these tests. I've never seen a 50-year-old woman or a 40-year-old woman have a youthful level of DHEA. Now, there's probably a window of time, and I don't see many women in their 30s. There's probably a window of time where a woman can be, if we measured her, producing excessive levels of DHEA. Why would she be doing that?
Yeah, exactly.
Because she's stressed. And when her glands are young enough, they're capable of these exuberant outputs, even greater than normal basal levels for a young, healthy person. So in order to get an elevated DHEA, one of two things have got to happen. You got to be young, you got to be stressed, and your tools for dealing with your own emotions, mind, and life are not up to what they need to be. So you're going to be producing excessive amount of every animating hormone you can name, including DHEA. And you're going to do that for a while until your glands can't keep up with it. In which case you're going to get declining levels of DHEA and estrogens and progesterone and testosterone and thyroid, etc.
Right. And
that's one of the hallmarks of consistent stress that's not being met by skills of emotions and mind and life.
Yeah. I mean, the term anxiety comes up a lot. Yeah.
Well, that's a side subject we could go down to, but I'm not going to go. I'm going to stay with the biology for a minute here. Now, there are rare exceptions. There are actually adrenal tumors that can produce excessive levels of cortisol or excessive levels of DHEA. There are actual tumors that can do that, even tumors of pituitary that can cause overstimulation of the adrenal glands and get elevated levels. So in 25 years, I actually detected on a 24-hour urine hormone test three major elevations of DHEA. One in a man, and we tracked him down to have he was Italian, of Italian genetics, and he was young, and he happened to have genetically elevated levels of DHEA that were uncommonly high compared to the general population, but he was not ill. I also detected an adrenal tumor in a woman. The hormone levels coming out of the adrenal were way too high. We did I forget if it was a CAT scan or an MRI, and indeed there was a small tumor there. And when she went into surgery, we had detected that early. The anesthesiologist even commented to her that he had never seen an adrenal tumor be extracted at such a small size.
Wow.
24-hour urine hormone test picked up on that.
Nice.
She was not symptomatic. So that's rare. These adrenal tumors can produce excessive DHEA. They can produce excessive cortisol. And they're extremely rare. And then the contrary is what's really happening. Most men and most women by midlife or even in their 40s have declining levels of DHEA. Here is a maxim for women. Do not take more than 15 milligrams of oral DHEA. My mentor, beloved Alan Gaby, medical doctor, told me that guideline, and it turns out to be true because we test women. And you don't want to take more than 15. There's some women who they'll get excessive levels of DHEA if they take 12.5 milligrams or 10 milligrams a day. But like the safety valve is don't go higher than 15. And we always rely on testing. DHEA can be given orally. Unlike estrogen, which we do not want to give orally because there's possible adverse consequences of that. Unlike testosterone, which can injure the liver, we don't want to give it orally. And I don't even think you can give testosterone orally. But DHEA and progesterone you can give orally. But women, do not take more than 15 milligrams. And I was walking through one of those big box pharmacies one day, and at the checkout counter, there was this cardboard display, about 4 feet high, 2 feet wide, had hundreds and hundreds of bottles on there. It was DHEA 25 milligrams.
I bought 50 milligrams way long ago. 50 milligrams. Never took it, but I did.
Yeah, they're readily available, and so don't do it. Don't take higher than 15 milligrams if you're a woman.
Kind of scary.
And testing will really show you where you're at anyway. So, DHEA. I don't think I have more to say about it. My favorite way to give DHEA is we combine it with our testosterone, and we give a mixture of testosterone and DHEA topically, and we confirm that you're at adequate DHEA levels by 24-hour urine hormone testing.
Got it. And thank you so much. DHEA isn't something you hear about all too often when you're younger. You get older, you hear about it. So I'm gonna ask you a question. My daughter has 3 children. She's now in her 30s, and she wants to have a full hysterectomy. She is plagued with really erratic menstrual cycles, confused about hormones. She just really wants to have this hysterectomy, and she's wondering if you think that, her having a hysterectomy is a good idea in regards to what it is that I just mentioned. Would the hysterectomy make everything better for her?
Well, I don't have enough information. And hysterectomy is in the province of the advice of a trained specialist called a gynecologist. And I've had the great privilege to know and work with terrific gynecologists. And here's the hallmark of a great surgeon. And I think the world was loaded with great surgeons at one time, certainly when I was in medical school and our surgery rotations, we were taught this. Here's how the great surgeons behaved. They took great pride in when to do surgery and when not to do surgery.
Right. Yes.
And that was one of their special. I loved it. I love the University of Michigan and to listen to surgeons. They wanted to do surgery when it was proper to do surgery, and they did not want to do unnecessary surgery. And they really held it to be of a level of the highest integrity to only choose to do it when it was the right thing to do. Now, no one's perfect. Sometimes you risk on the side of better do it rather than wish you had. So it's not a perfect science. This is part of what's called the art of medicine. And there are gynecologists that I've worked with that I've had just wonderful confidence in. I'm not going to say that about all the gynecologists that I've encountered. The medicine has changed since when I was growing up. It's a little bit disconcerting, big time disconcerting. But it's incumbent upon everyone who's treating women in menopause to know and be able to refer to an expert gynecologist.
Absolutely.
And one of the things they're going to do is they're going to assess this 30-plus-year-old woman's situation and give her advice about hysterectomy, and not just going to want to take her uterus out, which has become, I'm sorry to say, it looks to me like an excessive tendency to just remove the uterus and over the ovaries. My God, I know women who've had endometriosis that surgery was life-changing for them.
Absolutely.
They needed it. And they also needed an expert surgeon to do it. But I don't know what the indications are. A woman who's had 3 babies, there's a lot of women who've had 3 babies that are terrifically healthy and have normal menstrual cycles, and there's a lot of women who don't. And they start getting into premature ovarian decline. So their hormones aren't on time and aren't doing what they used to, and they get erratic cycles. They can get heavy cycles. If there wasn't uterine fibroids or uterine cancer or ovarian trouble, and all this can be evaluated by a gynecologist. For example, a transvaginal ultrasound can tell you a tremendous amount. And of course, they have more sophisticated testing than that if they need it. You don't want to miss something really not good going on. We never want to miss things like that. But that's not the most common things that happen. And when I hear the story, I don't know enough information. But the next step is, does the woman have a gynecologist that she really trusts? And does she have a gynecologist that takes that tremendous pride in let's do surgery when it's needed and let's choose not to do surgery when it's not needed? And
Great
then
point.
there's another combination. If it's a hormonal depletion and imbalance thing, sometimes this is not the gynecologist's favorite expertise. Gynecologists have tremendous training in surgery. My God, they go through a surgical residency, I don't know these days, of 1 or 2 years, just a general surgery rotation. Then they go through, 3 years of specializing in gynecology, and then they can go on to specializing within the field of gynecology. Gynecologists, medical doctors tend to sort according to two loves: those who love the medicine stuff and those who love the surgery stuff. And those who love the surgery stuff, orthopedic surgeons are notorious for this. And those who love the surgery stuff, they don't necessarily like the hormones or the medicines and stuff like that. Some of them do, but a lot of them don't. They're there to, and my God, gynecologists have supported me so many times in my career, but they're not necessarily experts in hormones. And so, if this woman has a hormonal imbalance thing, if she were to go to a gynecologist and the gynecologist says, geez, your ovaries look good, I've done some special testing on it, like a transvaginal ultrasound, your uterine lining looks okay, you don't have uterine fibroids, I don't see any pathology here, maybe this is a hormonal balance thing. Then you get yourself to a hormonal replenishing expert, someone who's specializing in treating women in menopause with compounded bioidentical hormones. So I don't have enough information to advise about this other than say, get a gynecological workup. Be sure you choose a gynecologist that you can talk to and trust, and one who's going to be very discriminatory about, hey, listen, we love to do surgery when it's the right thing to do, and we choose not to do surgery when it's not. This is a hormonal imbalance problem. Get thee to a hormonal balance specialist. So I know that that's not a specific answer for this mom who's asking the question about her 30s plus daughter. But what there is to do is make sure that you're with one of those gynecologists that has that just impeccable integrity around when to do surgery and when not.
Integrity.
And then if they say, hey, look, all systems go here. There's no surgical pathology. There's no endometriosis in here. There's no ovarian problems of any kind here. No ovarian pathology like ovarian cancer. There's no uterine cancer here. There's no uterine fibroids. There's not a surgical issue here. This is a hormonal imbalance issue. Get these hormones balanced. That's what I would want, is gynecological clearance that a workup has been done and, hey, things look good in there. It's hormones. It's hormone imbalance. That's what, or they'll say, no, you got uterine fibroids. These are beyond the pale here. You need to get this uterus removed. And we don't necessarily need to take your ovaries because they look good. Or sometimes you need to take the ovaries too, if there's problems there. The thing about a total hysterectomy, that means uterus plus ovaries, is you want a hormone replenishment expert before you go into that operation.
Oh, you betcha.
Because you want to get that one right. And if you couple a total hysterectomy with an expert at hormonal replacement, it's fine. It's just like natural menopause in a certain way. It's I can't even tell the difference. If I didn't have in our history form, did you have a hysterectomy or not? Total hysterectomy, removing the ovaries as well. I couldn't tell the difference between a woman's symptoms who had a total hysterectomy and a woman who went into natural menopause. And they're both treated pretty much the same. So ultimately, just do the right medical thing. That's the thing. And with due diligence, good doctors, they know how to guide you towards the right thing to do, because there's always a right thing to do. There's always a right choice, whatever that choice is. And that's what doctors who really love medicine and care about it, They know how to follow the bouncing ball to guide you into what the right diagnosis is and what the right choice is. Got to find one of those folks. They're beautiful.
And they're out there. I know they are.
They are out there everywhere. There's
They are.
good doctors and good nurse practitioners everywhere. And I know people have had some untoward experiences with some, yeah, in every field, attorneys, bus drivers, every field that you can name. There are the great ones, and there's the ones who shouldn't be doing it because they don't care that much.
No joke.
So your job is to find someone who really cares about it.
Yes, true. And you've often said, and it's so dear, and I agree with you, that when you go in the hospital, it's the whole staff, you know, from the trauma surgeons to the janitors to the cafeteria people to the doctors and nurses and everybody. It's a big family. And I've always been comfortable in that world, you know. And I appreciate that you bring that up because these people matter. In our last 4 minutes, I don't know, Dr. R. Shouldn't I? I'm going to start out with this one next time, and I'm going to ask you one question from our sweet Antoinette, and she says, maybe if you can answer this for her, how do you know if you're getting too much testosterone?
Too much testosterone?
Yeah.
Gee, I was looking at another question here from Antoinette too.
Oh, Antoinette, which one should we answer?
Both of them. You have to take your bioidenticals every day. Can you go every other day if you feel like you're getting too much?
Yeah.
Well, that definitely would not be what I would recommend, Antoinette, because our bodies never do anything zero every other day.
Right.
So if you are getting too much, we can adjust your dosages so that you get the right dose every day. And I'm always an advocate of that. Sometimes twice a day.
Yes.
We break down estrogen, for example, twice a day.
Yes.
But that's part of the process of getting your hormones right, is to adjust those doses that are individualized for your body. And they vary woman to woman. And so you should. Is we get it down to what's the right dose per day. And yet, you know, as an interim, figure it out every other day won't hurt you.
Right.
It's just not the optimal way to ultimately land.
Yeah.
And sneak preview, we're hoping to come up with a major cost savings to women on hormones. And how did I get there? Because sometimes you got a whole big bottle of something or a jar of something and you go, oh God, I just can't rush out and get another new jar because this stuff is not inexpensive. So you learn how to parse out your inventory differently.
Right.
And that's sometimes where these questions, I'm not saying it is with you, Antoinette, but that's why sometimes these questions come up every other day. But eventually we get these dosages down to what's individual for you. For example, in my practice, I'm going to throw out numbers. They're not going to be meaningful to you. The women, the average amount of biased comes down to 1.7 milligrams of estradiol equivalent per day. But there's a range. Some women, they do really terrific on 0.8 milligrams of estradiol equivalent per day. And others they need 2.6. Look at that wide range. That's more than 3 times the low amount for the upper amount. So I'm just pointing out that there is a wide range of individual variation. And ultimately, our goal is to zero in so you get the right amount. And I did drop a big balloon there. The Menopause Method is actively working on a cost-saving event that if we're able to sign the contract, these hormones are going to come out much less expensive to all of you. So we'll let you know what we posted on that.
Amazing.
I can only give you a sneak preview. And that would be all I am able to do today because of other commitments of my time. We did it. We ran it.
We did it. The bewitching hour is here on the nose. David Rosensweet, MD, you're amazing. Thank you so much for answering our questions always. And thank you, ladies, for coming up. Thank you, everybody. It's early, but happy Halloween. These are going to be stuck to my head for the next 28 days. And I'm just going to wish everybody lots of love and happiness and health and fun. And let's just keep it moving.
All righty. So until Thursday, right? Yes. We'll see you on Thursday, everybody. And thanks, Carolyn. Thanks for doing what you do.
Yeah,
Really
my
appreciate
pleasure always.
your
Indeedy,
sourcing of this.
Yeah, it's fun. It is satisfying, and I'm working with the best. So what more can you ask for, right?